do this long. Yeah. Okay, we might get started. So I've got a long opening here, so I might start that if we're good to go. So I declare open this hearing of the Senate Community Affairs Legislation Committee's inquiry into Aged Care Bill 2024 provisions. I begin by acknowledging the traditional custodians of the land on which we meet and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. The committee will be conducting today's hearing via teleconference and in person. I'm Senator Anne Urquhart, Acting Chair of the committee, and I have with me Senators Ormond Payne, the Deputy Chair, Senators Kovacic and Senator Ruston in person, and Senator Pratt will join us via teleconference. And Senator Smith also, Marielle Smith, who is the proper chair, will join us by teleconference. Yes. These are public proceedings being audio streamed live via the Parliament's website, and a Hansard transcript is being made. I remind all witnesses that in giving evidence to the committee, they are protected by parliamentary privilege. It is unlawful for anyone to threaten or disadvantage a witness on account of evidence given to a committee, and such action may be treated by the Senate as a contempt. It is also a contempt to give false or misleading evidence. Witnesses also have a right to request to be heard in camera. If a witness objects to answering a question, they should state the ground upon which the objection is made, and the committee will determine whether it will insist on an answer, having regard to the ground which is claimed. If the committee determines to insist on an answer, a witness may request that the answer be given in camera. I now welcome representatives from BAPCare and the Pharmacy Guild of Australia. I understand that information on parliamentary privilege and the protection of witnesses giving evidence to the Senate committees has been provided to you. For the Hansard record, would you please state your full names and the capacity in which you appear today? And once you've done that, I'll invite you to make a short opening statement. So would you like to start, Ms
Thanks,
Alberti?
Senator. My name is Sylvia Alberti. I'm the Chief Operating Officer at BAPCare.
Thank you.
And hi, Senator. My name's Jai O'Malley. I'm the President of the Pharmacy Guild of Tasmania.
Thank you. So I now invite you to make a short opening statement, and at the conclusion of any remarks, I will invite members of the committee to ask questions. So who would like to start?
All right, well, I might lead off then. Thanks, Senator. So my name's Jai O'Malley. I'm a community pharmacist. I'm the recently elected President of the Tasmanian branch of the Pharmacy Guild of Australia. The Pharmacy Guild of Australia is probably pretty well known to all of you. It's community pharmacy's peak body organisation, services the needs of the 6,000 community pharmacies around Australia and their patients. The Guild strives to promote, maintain and support community pharmacies as the most appropriate primary providers of healthcare to the community through optimum therapeutic use of medicines, medication management and related services. Community pharmacy is consistently seen by the Australian public as a trusted and valued part of our nation's healthcare system. Community pharmacies exist in communities right around the country and are the most accessible form of primary healthcare. Pharmacies often operate over extended hours, 7 days a week, and in rural, regional and remote areas. And I would thank the committee for bringing itself to Devonport, which is 10 minutes drive away from my home today to regional community. As community pharmacists, we provide timely, convenient and affordable access to the quality and safe provision of medicines and healthcare services by pharmacists who are highly skilled and qualified healthcare professionals. The Guild and the pharmacy network across Australia has been a long and credible record of delivering evidence-based programs for government and consumers, consistently demonstrating a capacity to deliver significant outcomes within substantial budget and time constraints in often complex and multi-organisational frameworks. The Guild enjoys strong relationships and a positive influence across the pharmacy and primary healthcare sector, and is regarded as a thought leader not only in the current environment but in shaping the future of community pharmacy through productive collaboration. We welcome the opportunity to speak to the committee today. Thank you.
Thank you.
Good morning, everyone, and thank you very much for the opportunity to be here. As I said, my name is Sylvia Alberti and I'm the Chief Operating Officer at Baptcare. At Baptcare, we provide services that are community-based services and aged care services across Victoria, Tasmania and South Australia. Of particular relevance to this legislation are the services that we provide to over 4,700 people in aged community care and over 1,500 people in residential aged care. We started the provision of aged care in 1945, which I think predates when government provided assistance to people in need, and from that time have really held a steadfast commitment to high quality of care, but more importantly for us and for many in the sector, it's a commitment to independence, to dignity, to choice and to compassion in the way that we care for people. We would like to say first and foremost that we welcome this Act and we support its passage urgently and as a priority. We're particularly excited about the rights-based focus of the Act, and we think that this has a real transformative opportunity to reorient all services and the entire system actually around the needs of individuals, and we think that that's a fantastic place to be. For that reason, we're really hoping today to talk about some areas that we think could be strengthened, particularly with regard the impact that those areas will have on consumers and on the broader community. One of the primary things that I did want to talk about today was the significant time, effort and work that will be required to implement such an incredible change that is so complex and at this scale well. We know, for example, using support at home as one of the examples, that the change required to implement it successfully will mean that we need to change our operating models, we'll need to change the way our teams are structured and work, we'll need to change the software that actually supports the work to occur. We know that we will need to ensure that we've tested the change in that software with interfacing systems like our HR system, our rostering system, our finance system. We know that all of that takes really careful planning and really careful testing as well, because the impact is on thousands of people if we don't get this right. We know, for example, using support at home, that nationally the main complaints that go through are around consultation, communication, fees and statements. All of the changes that we've just talked about in support at home relate to those four areas. For us to ensure the best possible outcomes for consumers on the ground, we would need at least 12 months from the time that the specific rules are set in order us to work with our software developers, with our teams, to train everybody, and then to be able to do really good consultation with consumers so that they understand what these changes mean. The grandfathering provisions will also then mean that for many of us we will be running a dual track system, and that adds more complexity. It adds complexity not just in the service to be delivered, but in the systems that have to be created to automate those flows. So I think that the time that we're seeking is time that would be spent building that and actually testing it, and particularly testing interfaces like those with Services Australia. The other provision that I think really does need a little more time is the supporters provision. This is really very important and directly impacts individuals, it impacts their families, and it impacts the people that care about them. When we have to use these provisions, there are usually great complexities at play. We need them to be very clear. We need to be very clear about the authority for decision making in those circumstances. As it stands, this is unclear. Presently, we all have systems that we're able to use and continue using. We think that nothing would be compromised in taking some time to really work these through carefully, and in particular thinking about the jurisdictional interfaces with third parties, with advocates, with everyone, so that when we actually roll these on the ground, they're clear for all of us to use. Importantly, they're really clear for individuals and families where this is going to be a decision-making entity. The last one I wouldn't mind talking about is the whistleblower provisions. We really support these in spirit completely. We have, for example, in our organisation, really clear whistleblower policies and procedures. We have trained people that are able to take disclosures, that know how to act swiftly and know how to act appropriately around protected disclosures. The Act suggests that any aged care worker could take a disclosure. We don't think it's possible across Australia to train thousands of people to take these disclosures and know how to act on them appropriately, swiftly. And so we don't think that that's actually a good position to put our staff in, and it's not a position that we would like to put the public or anyone making a protected disclosure in. We believe these are really important disclosures, and the people that take them need to understand very carefully how to manage them appropriately. So thank you very much for the opportunity to be here and to spend some time with you talking about it today.
Great, thank you. I might go to the opposition first, and then I'll come back to Senator Allman-Payne. So who's going to lead off? Senator Ruskin? Thanks.
Thank you. Just going back to some of the comments you've just made, Ms Alberti, I mean, they, particularly around the timelines and the costs, you made mention that you thought that you would need a 12-month timeline. Has your organisation gone into the kind of depth of what are the kinds of things that would require 12 months, and what are the kinds of changes that could be implemented before that? So interested to understand what sort of implementation phasing you think would be appropriate, and are there things that are particularly of concern to you there?
Yeah. So much of the supported home process changes the levels. It changes the degree of, depending on service type and level, what the billing will look like, what the co-contributions will look like. All of that means that every system, from the moment you onboard somebody, all the way through to the time that someone is exited, needs to be changed. So, for example, our client information systems, where we're recording information constantly, our rostering systems, so that we're able to check the hours of service delivered against any individual in any month in time, our HR systems to make sure that all our workforce is credentialed appropriately and able to start, our billing statement system at the back end. So all of those need to be changed, and then because of the provision to only hold a certain amount of funds and the rest is held in Services Australia, and to do that more frequently, we would have to enable the transfer of information across all our internal systems and then the external system. So the question of phasing is a complicated one, because depending on the element you phase, you would still need to have that system interoperability sorted for that element. We know from the conversations that we're having with software providers, and in our case we have our own Salesforce system which is end-to-end, that we would firstly need to know the specific requirements, and right now we don't have those specific requirements, and we don't have visibility of when we will have them. Those requirements would enable us to do that more detailed planning with our software supports, and also with all of our end-to-end systems so that they're working. Typically, we would then test it on a small group of people. We would talk to our consumer advisory group about that. We would plan a test and we would run it. The issue with phasing is that any one of those small components would require us a change in the end-to-end system. So I think where we've seen really good success when we've done larger and more complex changes, it's when we've had the opportunity to build in the time needed to change our systems. And importantly for this one, it's also the interoperability with systems that are outside of our organisations, like Services Australia.
Yeah. So in terms of that, so you made the comment that the timing of the specific requirements, obviously there's a lot of this is contained in the rules. We haven't seen the rules.
That's
and we don't know when we're going to see the rules. So, you did actually make the comment that 12 months was the time frame from when you knew what was required of you to enable you to get to that point
That's
in
right.
time. So I suppose the fundamental question is, in terms of your operation, if you don't see the rules, and I mean I suspect we won't see the rules some of them till next year. Are you suggesting that we probably are not going to be in a position to effectively, efficiently, and without great risk put in place what we need to put in place for some of these things by the 1st of July 2025?
I can't see how we could put in place a change when we don't know the rules.
Yep.
And we don't have the systems built to do that. And we're not talking about 10 people, we're not talking about 100 people, we're talking about thousands of people in the community. And we're talking about a system that is already quite tricky to navigate for people. And we spend a lot of time with our advisory group and with people trying to help them to understand statements and billing. And, it is a complex, it is a complex thing. And I think if we don't do this well, ultimately people lose confidence in us and in the system. And that's not the outcome we would want from a once-in-a-generation act.
Sure. To that end, then, have you got any idea, or have you factored in terms of your budgets going forward, the kind of additional costs that is likely to be borne by your organisation? I mean, you're not small, but you're certainly not large by the extent of aged care providers in Australia. Have you got any idea about what these systems changes are likely to cost you in terms of financial dollars?
It will be millions.
Millions, yeah.
So we run our own system. It's an end-to-end system. It's based on a Salesforce platform. And when we take changes to that system, it does cost millions.
So do you have any understanding whether there's going to be any financial assistance? Because we know in the last budget there was about $1.5 billion was in the aged care budget for IT systems changes. Have you, so take a step back, have you been consulted about the impact of these changes and what's expected of you from these changes by the Department of Health and Aged Care?
It may be that our peak ACPA has been, and I really can't speak for them. From a BaptCare perspective, no, we really have what's available in the public domain. We don't have the rules. That is a cause of concern for us, because the rules, whilst not in the purview of the Act, the rules really give us the specification. The specification gives us the tools we need to then redesign all of our systems. And I know that I speak for everyone when I talk about this, because this will affect all of us. Even if you're running manual systems and you're very small, you have to reconfigure everything.
So in terms of what you know today, notwithstanding the fact that we haven't seen the rules, have you got any concerns about additional compliance reporting or the like that is likely, or additional burden of that going forward? Notwithstanding you've probably got a view about the level of compliance and reporting you do at the moment. Is there any additional concerns?
Look, there's always a worry when you aren't clear about the specification about what will that mean in terms of the data to be collected. And I guess I'll say at the outset, we want to be held to account on our star ratings in compliance. We are at 4s and 5s, so we are really committed to this. However, I would also say that some of the reporting that we do is at such granularity that the onus on us at that granularity to report is enormous. And we're talking about, hours and teams of people that are doing it. So I think it's really important to be accountable, to be transparent, to provide data, and we do that, and we are very proud of our record in that regard. We would also like to see, some of the reporting take a more material, meaningful impact.
Yeah, sure. Can I just quickly, because I'm sure we're out of time, just pick up on, you made some comments around the implications of the supporter provisions that are in the Act. I noticed we've taken, that we're now down to only supporters as opposed to responsible people. You made the comment that these are often complicated and the interjurisdictional nature of it. Do you find that at the moment that the power of attorney provisions that exist within the states and territories are providing you with a reasonably adequate mechanism by which you can have a representative person being able to act on behalf of somebody who's in your care, and what are your specific concerns around this new provision for supporters?
Look, I'll give you an example. We had a resident taken, her partner came to the facility late in the afternoon and took her home. The family were not in harmony with what was in her best interests. She had significant cognitive impairment. We had provisions and used the provisions that were available to us in that particular jurisdiction. We worked overnight and through the weekend, accessing supports, including the police, including the public advocate, and we were able to work our way through that. If these provisions came in, it would be very unclear who takes the decision and which state or Commonwealth jurisdiction is the one that we lean into for approved and authorised decision making. In those situations, they're very complex, they're fraught with emotion for family members. It's very difficult for our staff on the ground. You're thinking about RNs and care workers who are trying to manage their way through this. And they need to be fundamentally clear about who do we call, who do we notify, how do we know the person is safe, and who's making a decision about this. So right now, that's not possible given these
Sorry, take a step
conditions.
back. Right now, before the Act, you are reasonably comfortable
Yep,
that the provisions that are in
absolutely.
place are working
Yep.
for you?
Yep.
This just adds a level of
That's right.
complexity and confusion on top of it.
That's right.
Okay.
So that's why we're saying we think that nothing would be compromised if we pushed this part back, allowed people to work through it carefully and clearly and across jurisdictions. We would keep using the provisions we have always used. We're using them right now.
Yep.
Nothing would be compromised.
Okay. And just finally, in relation to, you made some comments around the whistleblower provisions. So have you actually put together what is the existing provisions? Do you believe that the new provisions are existing provisions adequate do you believe in terms of the capacity for the disclosures, protection of whistleblowers, etc., existing, and are you concerned that the provisions that in this Act sort of act outside of what is normal practice and is delivering? I mean,
I think, look, in principle, we're really, and the spirit of it, we're really supportive of, because it does actually enable a consistent approach right across aged care.
that isn't the case at the moment?
I couldn't comment about any other service in the sector. I'm not that close to the detail of some of that. I can speak about Baptcare and the fact that we have really strong whistleblower policy and procedures. That's very clear. The thing that I think really needs to be tightened here is around who is able to take that protected disclosure. Because as it stands, it suggests that whoever is defined as an aged care worker may take a protected disclosure. That's thousands of staff. And we worry, A, that they wouldn't be able to be trained to understand what does that mean and what's required of them, and B, that it's not appropriate for them in their role and duty that they take on that function.
Great, thank you.
I might just rotate the call. I'll come back if I've got time. So I'll go to Senator Orman-Payne.
I won't be too long. Morning. Thank you very much for appearing before the committee today. Ms Alberti, in your opening statement, you mentioned 4 things that you said were always issues or matters of concern, and I got down 2 of them, consultation and fees. Could you just tell me what the other 2 were?
So this relates to community aged care, and it's consultation, communication, fees and statements are typically what the Commission highlight as the main complaints.
Yeah, all right, thank you. Just in relation to the rights-based framework, you talked about the fact that you think that the changes, it's transformative, that it'll be a good thing. Interested to know what, practically speaking, will change on the ground in your system or your service with the introduction of the rights-based framework? Like, what does that actually practically mean on the ground?
On the ground, we already operate a pretty strong person-centred approach to care, and authentically that means people are engaged in their planning. If they have families, they're engaged. It means that we have advisory groups. We have those advisory groups providing advice all the way to our board. We have a range of activities, food on our menus that our residents or our consumers actually help to design. I think the component of this that's transformative is not about individual entities, but it's about the entire system, taking a rights-based approach. And right now, that's probably not consistent across our whole system. And so I think the transformative kind of application of this is really making sure that everything that we do in aged care right across Australia is focused on the individual and what's in their best interests. And that's as defined by them.
Yeah, I guess
not by us.
That's a fairly broad range. I guess I'm interested to know on the ground, like, is there anything in here that practically changes what your organisation does? I mean, apart from the fee structures and those new arrangements that are going to require change of systems, in terms of actual care, what in this Act means that it's more likely that someone is going to get good care?
Well, I think that right now a lot is left to the individual entities' determination about what person-centred care might look like. In our case, we have always bred that into the way we go about our work. And we have, our feedback from our consumers and families would attest to that. I guess what I'm suggesting is on the ground, that's the kind of thing that you would expect everywhere. You would expect a voice. You would expect that people have choice. You would expect dignity in choice. You would expect greater independence. You would expect that people wouldn't just be asked, but would genuinely be involved in construction of their menus, in choosing their activities. You would expect that they would have relationships with the people that provide them with the service. You would expect that they would have support in decisions around their medications, support in decisions around their care and how they receive it. Those are things that are so intrinsic to your own individual dignity and need to be really something that's consistent right across the system. I think the Act says this is a requirement of everybody that is a provider in Australia.
Do you think that the enforcement, there's sufficient? I mean, one of the things that the Inspector General has said in his comments is he thinks it's aspirational, that it talks about those things, but it's not necessarily clear that people will necessarily, like, enforcement mechanisms aren't clear, how the complaint system works isn't clear. Do you feel that's the case, or is that?
Well, I think it goes to some of the conversation we were having before, that this is the Act, which is the umbrella, and then there are rules. There's the Commission that will also have specifications. There are standards that would define what's the evidence of this occurring on the ground. There's an independent complaints commissioner. I actually do think that there are a range of mechanisms that would hold us to account, and that this will be a matter then of us being able to evidence how we're doing that. And so I do think that those other complementary and important mechanisms are the ways that you actually test on the ground. What does that mean and look like? And how can you genuinely evidence that you're doing that?
And so do you think it's the case that that is actually where the rubber hits the road in terms of how we actually measuring that quality of care is improving?
Yeah, I think you can't have that without an authorising environment. And this Act provides that authorising environment. It provides the architecture. It also talks about what's important to us as Australians. This is important to us. So I think this is an incredibly important Act, and it's a once-in-a-generational Act. And then I think, yes, the rubber hits the road when you understand how do you measure that it's being implemented in good faith and as well as possible.
Yeah.
Yeah.
We heard a lot of evidence from the department yesterday about RADs and DAPs and the fact that the RADs will go up to $750,000 before you need to get an exemption. Does your organisation, what percentage, if any, of your rooms would your organisation have applied for an exemption for to go above the current cap in the last 12 months?
I'm going to have to take that on notice, Senator. I haven't got that figure at the back of my mind. I'll have to take it on notice. I'm very happy to come back to you with some information if that's helpful.
Yeah, be interested to know what percentage of your residents pay a RAD versus a DAP, and how many exemptions you've applied for in the last 12 months. In relation to the changes around the minimum age in the Act, so the Act will stipulate that the minimum age is 65 with those exceptions around homelessness and for First Nations people. Would that change affect many people that are in your aged care facilities?
No, it wouldn't. With the exception of, and this is where harmonising the NDIS and the aged care provisions becomes really critical, we have made decisions, particularly in a couple of our rural areas, where people have grown up together in a home for most of their lives. One of those people, for example, needs to come into aged care, but that would break them up as a family unit. And so and their families really want to keep them together. And so we have made exceptions and taken both people. Now, one of those people is younger than that cut-off. I think it's the right thing to do because they're a family unit. They've grown up together. Their families have come together. So I do think that you have to hold a provision of exception in special circumstances, and the harmonisation with the NDIS I think is one of those areas where you really do need to think more about how we do that, because you know there are circumstances we see around that where it is in the genuine best interests of the people that they continue to live together and have a family life together.
So the current provisions then would prevent that, wouldn't they? Because there's very limited exceptions.
It is my read that they would. And look, it's not at all that this is kind of an overwhelming proportion of people, but there are some exceptions where you would want that to be an exception. Yeah.
That's all for now, Chair.
Okay, great. I might go to Senator Pratt if she's online. Maybe not yet? No. Okay, I might just ask a couple of questions of Mr O'Malley and then I'll head back to the opposition. So, Mr O'Malley, I'm interested in what the role of pharmacists is in aged care. Obviously you dispense medicines and a whole range of other things, but what role do pharmacists play in aged care, and how do on-site pharmacists in residential aged care help to reduce that medication-related harm?
Okay, well, thanks for the question, Senator. In terms of pharmacists in aged care, I guess the way I think of aged care is 80% of aged care at the moment is occurring in the home and in the community, and the 20% that we perceive as being residential aged care or nursing homes or similar terminology is ultimately closer to end-of-life care than aged care. Majority of Australians now that are in residential aged care facilities are much older and have more complex medical needs than they would have done a generation ago, simply because we're ageing in place better. So the majority of our members, of my members, are looking after those people while they're still ageing in place and ageing at home. You know, and there's, you know, in terms of the services that pharmacists provide, I mean, there's dose administration aids, which is DAs, which you're all probably very familiar with. These are often delivered 24 hours a day, 7 days a week, both to people's homes and to aged care facilities. And particularly with Australians in aged care facilities, they often need more care in the last 3 months of their life in terms of palliative care, and they are required urgently. That's a significant impost on the care provider then to make sure that's available. You know, with members, with pharmacists that are looking after patients in aged care facilities, there is another level of complexity around that, engaging with a provider. There are many providers, some small, some large. There's auditing, there's additional compliance and meetings to attend. You questioned specifically about the aged care on-site pharmacist. I'll have to take on notice. That's a relatively new role and program, and it has certainly seemed to have a promising start. I can't imagine that having a pharmacist more involved in a person's care on site at a facility is going to be a bad thing, though. Like, ultimately, you know, your pharmacist is meant to be a medicines expert. If they're more available to the residents, to the staff, to the care staff and the nursing staff, then that's got to be a good thing. I think there's opportunities in both areas. So, you know, community aged care and residential aged care in a couple of areas, which I'd like to give examples. And the first of those would be the electronic medication charting. So there's a number of different products available at the moment. And while I'm not an aged care expert, some of the products seem to foster, I guess, patient-centric care better than others. I think we're all aware of the pinch points in our health system at the moment that rely on one particular person to do a particular thing at a particular time. And at the moment, that's usually provision of a prescription or an order by a GP, by a doctor, often not at the aged care facility. They have to write a prescription, transmit a prescription, it has to be received. There's a lot of administration, I guess, involved in that, and ultimately that leads to a delay in therapy, a delay in treatment, which is a bad result. So I think some of the systems that are available at the moment, you know, are less reliant on something having a number of manual steps and ultimately speed up treatment while still having, you know, checks and balances, etc. And that's perhaps something that could be looked at moving forward, because a delay in treatment, again, is a bad result. And I could give you numerous examples from this week from my patients, but, you know, we had an 88-year-old lady who's ageing in place at home who rang us half a dozen times on Tuesday afternoon for an antibiotic prescription which she'd obtained, you know, via telehealth. The prescription hadn't been written, it hadn't been transmitted to the pharmacy, it wasn't on a prescription list, so she is an 88-year-old but very adept at getting electronic prescriptions. And ultimately, you know, we had to deliver that last minute at 5 minutes to closing because that's when it was available. Now that's something I feel would be a relatively simple fix, maybe not easy, but simple, because there's issues with technology and also regulation with the Digital Health Agency that would need to be negotiated, but I think we could do better with that. The other example I'd give is with sort of preventative care. So pharmacists have been able to go to people's homes and administer COVID-19 vaccines for the last couple of years at least, and we've had permission and support in terms of funding to do that. That sort of permission and support isn't available for the NIP vaccines, for the over 65s, over 50s for Indigenous Australians, and that seems like a disconnect. I think there's an opportunity there, and that's a much more cost-effective fence, if you like, to build at the top of the cliff than an ambulance to park at the base of the cliff. I think we need to do better with that. We need to be practical.
Thank you. We've got 4 minutes left. I'm happy to flip back to Senator Ruston.
Great. Look, just quickly, back to the aged care on-site pharmacist initiative that just came in on the 1st of July. I'm just keen to understand, you know, it is very new, but in terms of the community that we're talking about here, we're talking about reasonably small communities. How much uptake have we seen from a community pharmacist wanting to actually provide that service? And have we seen anywhere where a pharmacist or if a facility is sufficiently of size to actually have a pharmacist in the aged care facility, or are they all being provided by community pharmacy in the area?
Yeah, so that's a good question. So the colleagues that I've spoken to that have entered this area the last couple of months, it is through community pharmacy. The numbers are small. They might be on site 1 day a week, 1.5 days a week.
Is that sufficient for them to be able to receive the funding?
As I understand it, it is. But I'll need to take that on notice too.
Yeah.
I think with the aged care on-site pharmacist, there's a concern that there's not the workforce to deliver that as it should be delivered. Look, like a lot of areas of primary care, we're struggling to get the cattle right to perform the services, to do things, and this will be something else that we will need to dovetail into. You know, if I had an aged care facility with 200 or 300 beds, I'd need to look at, what would that be, 1.8 FTE to resource as an aged care on-site pharmacist. Personally, we've got 2 pharmacies on the northwest coast. I'm about 2 pharmacists down at the moment. We would love to have more. So it's a tough one.
Yeah, I suppose, and given the workforce constraints that there are at the moment, and given, you know, the funding that's available, on average, looks like the payment, if you were on an on-site pharmacist, would be higher than you would potentially be earning as a pharmacist in a community pharmacy. We just don't need, you know, sort of robbing Peter to pay Paul in a constrained workforce environment. There was also a requirement for additional credentialing in relation to being able to access this program. Has there been any concerns expressed about the process required for that credentialing, or has that not been an issue?
Not with the colleagues that I've spoken to, but I would stress it's small numbers in terms of uptake here. So I'm happy to take that question on notice too.
Yep, sure. And just finally, do you think the financial settings that are in place around this particular initiative and all of the other things that make up pharmacy within our aged care communities, wherever they are incentivising the best possible access to medication management and pharmacy responsibility for our older Australians?
I think there's elements of what's been implemented that are positive. I'm not sure the proof is in the pudding yet.
Thanks.
I share your concerns about workforce and having skilled people seconded or sucked out of community pharmacy to work in aged care. I mean, one or two things would happen there. They will either go, or ultimately my members will have to stump up a higher wage to maintain them, which has been an issue over the last 3 or 4 years already.
Yeah. Yeah, certainly my concern across the whole of the healthcare sector is that as soon as government comes in and provides a salary that is different to what is being provided in the community, you will get an adverse change of behaviour reaction that's not necessarily in the community's best interest. But I know we're running out of time, and I know Senator Kovacic had. Okay. Well,
we are out of time, but if you.
No, that's fantastic. I will continue my conversations with pharmacy as I do, because you know I'm a big supporter of community pharmacy.
Okay, we are out of time, so can I thank you for your evidence today? And I think you both took some questions on notice. So the committee will report to the Senate on the 31st of October, and we're asking any answers to questions taken on notice are provided to the Secretariat by the close of business on the 14th of October. Thank you. So the committee will now suspend and will recommence at 10:25 a.m.